All right, how's everyone this morning? I was thinking about doing a mean joke for the people that were caught in traffic because they'll probably have to watch this to catch up, and then I was going to be like, and that was the answers for the next test, and then I said, no, that would be too mean. I like to cause more anxiety in you people than I already do, so I'm not going to do that. I also normally like to wear shirt and ties for lectures. However, today's the day of the chili cook-off, and shirts are easier to clean than ties. I have no idea how to clean a tie. The one time I tried to clean a tie, it was not good. It was a total mess. So, and I will spill something on myself. So anyway, but it's good we're talking about chili because we're talking about GI stuff still, right? Cause of many a GI woe in some people's lives. But assuming, let's say we have some really, really terrible chili, and I'm not going to assume that, but let's just say we did. What might you need to treat the nausea and vomiting associated with that? Well, some antiemetics. Let's figure out what our antiemetics are going to be that we're going to use, not use for the chili today. We're using things to try to prevent us, and we can eat even more stuff. We'll look at some things that can help us with that. All right, so what are some cases we're going to use antiemetic drugs? Obviously, they're having active nausea, vomiting, right? When might people get motion sickness? On a boat, right? This is important. You were working relatively close to a port. We have a lot of people coming in from Port Canaveral or been on a boat and they get very motion sick. We see a lot of postoperative nausea and vomiting. We see that not only in surgery specifically, but like imagine in the ER. We have a lot of patients who are getting on things like procedural sedations. When I say procedural sedation, what does that mean? It really just is that easy. It's sedation for a procedure, right? So again, if you're having, say, a fracture reduced or a joint being put back into place or something like that, they're pretty painful procedures. We'll sedate them in the ER under close monitoring and all of that. We'll talk about drugs for those things later, but a lot of times they get very nauseous afterwards. And so, imagine if you have someone who's sedated and we are causing them to be very nauseous and they vomit, what could be a potential risk? Of aspiration, right? Because again, if they're sedated and not protecting their airway well, that's why we like to give things like antiemetics. We'll talk about the agents we're going to use there. The other big thing is nausea and vomiting, steaming chemotherapy. We've covered chemo already, and we saw that different drugs would have different emetogenic potentials, so how likely they are to cause you to throw up. But very, very important, right? Because again, it's multifactorial. If you imagine, you guys ever had like really bad like sushi or just like a really bad food, and the next time you went around that food, like you got this like anticipatory like nauseousness associated with it. Same thing happens with chemo, right? And so that's why we look at different things to try to manage that. So for instance, what's a med or a class that we use for anxiety, like acute anxiety? Or benzos, right? So again, we can do the same thing. For instance, we can use benzos like lorazepam as an antiemetic. It's not an antiemetic in and of itself, but it helps to deal with that anticipatory sort of nausea and vomiting that some of these patients get with drugs like cisplatin, cyclophosphamide. A lot of these like alkylating agents are very, very emetogenic. So again, it's another important thing there. And oftentimes, patients with getting chemo, they're going to get 3 or 4 different medications for that to try to prevent that emesis. So it'll be like Zofran, they'll get Ativan, they'll get Decadron, they're going to get something else, Prepotence. We'll go over all those drugs in a minute, but just know sometimes patients are good with just one medication. Sometimes we have to go with kind of a multifactorial sort of approach. So why do we get nauseous? Why do we vomit? A couple different things, right? There's kind of local and there's central effects. Local effects meaning that there's going to be receptors that are triggered in the actual GI tract. So say, for instance, here, if you're looking at this picture, you can see that there's some serotonin receptors. Remember, 5-HT is just serotonin. Note here, 5-HT3 is the main receptor type we're talking about. You can delineate that in your head. So imagine if you're talking about like migraines, you're talking about triptans, what receptor types were we talking about there of serotonin? 1B/D, right? 1B and D were the ones affected there. There we're using agonists. Here we're going to find we're actually going to block the effects of serotonin. That's going to be 5-HT3 antagonists. Okay, good to keep those different receptor types separate in your head. So those are local effects, right? So again, if you have local foods that have spoiled or have some sort of toxin associated with it, that's going to get that local effect trigger there. We also have what we call the vomiting center, the chemoreceptor trigger zone, and this is going to be more essentially mediated sort of an effect here, right? So you're going to find that different things can affect this, including things like dopamine. We're going to find things like acetylcholine, things like serotonin are also going to be very important for that chemoreceptor trigger zone. And if you can inhibit that, it's a very potent way to try to inhibit nausea and vomiting for these patients here. You guys already covered most of these medications in GI already. Please talk about them. Okay, we'll cover them again here, right? Just know it's complicated, right? If you remember a drug that I'm very proud of back from physiology, I said they have that mesenteric nervous system. So anytime someone ever calls you a smart ass, you can be like, I actually am. I have a very smart, nervous system right there just from my GI tract. It's very complicated, right? So again, there's a lot of different pathways that are associated with that. And just know that, we have a lot of different medications that can attack that from different aspects. So so first off, let's talk about our antimuscarinics and our antihistamic drugs. Some of these are just going to be purely antimuscarinic, right? Because again, if you think about it, go back to muscarinic agonists, right? So acetylcholine agonists that work on the muscarinic receptors. What was the mnemonic we used? Dumbbells, right? What was the E in dumbbells? Emesis, right? So again, if you can block that by using antimuscarinic, that's going to help to relieve that nausea and vomiting, right? Again, antimuscarinic typically is going to have antiemetic sort of effects there. So for example, there's one called scopolamine. Scopolamine is a very good antiemetic, only antimuscarinic activity there, right? And so we already know the side effects you're going to expect to see with something like scopolamine, which could include constipation, good. What else? Dry mouth, It's drying everything up, right? What else? What's our mnemonic for anticholinergic, antimuscarinic activity? Mad as a hatter, dry as a bone, red as a beet, right? I'll remember to go through that, right? Because again, I want you to be able to make that association very quickly so if someone ever asks you on rotation or something, what's an expected side effect of an antimuscarinic drug? You should be able to rattle that off pretty quick, right? Because again, we've talked about it ad nauseum, right? We're talking about antiemetics. Anyway, so this one's actually kind of interesting because it has to be, this is actually given as a patch. And you apply it basically behind the ear. Transderm scope's the typical brand name you're going to see for that. Very important. You want to wash your hands. Why do you think that is? You worry about absorbing the drug, but again, where might your hands go? Remember I talked about cutting up like jalapenos and stuff. Where do your hands always want to go to? Right to the eyes. This is actually a case where someone had actually rubbed their eye after receiving or putting on a transderm scope. They didn't wash their hands effectively and ended up getting that. If you saw that in a patient showing up to the ER, you should be very concerned, right? You should be thinking there's some kind of like pontine bleed or something else going on, that like something very serious, right? But the patient's like totally normal, not having any issues, mental status is good. Then you can kind of dig a little bit deeper to be like, okay, what's really going on here? And so in this case, it could be just that they had scopolamine. They were saying, oh yeah, I was about to go on a cruise in a couple of days, and then they told me to put this on, and then this happened. Okay, and you can make kind of tie two and two together there, right? Very good for motion sickness, but remember when we talked about like transdermal drug administration, is it a very like fast onset kind of thing, or is it kind of a little bit slower? Slower than like PO, slower than IV, what do you think? Well, it takes time for the drug to go through the skin, right? So it's a fairly slow sort of thing there. So imagine if you have someone who said, oh yeah, I'm going on a cruise tomorrow. When do you want to tell them to put that patch on? Like right now, right? You want to give them at least a few days if possible, because that's going to give time for the drug to get into the system and really kick in, right? Also, they're going to get a little bit tolerant to some of the side effects you're going to see with this, and we'll see what those are in a second here. If they put it on the second they get on the boat, it's not really going to be all that effective. Or say it's just a 3-day cruise, by the time they're done with the cruise, the drug may be really kind of kicking in full force, and they don't need to be motion sick anymore, right? Because they'll be back on solid land. So there's some issues there, right? But these are very good for motion sickness. They kind of help with that vestibular apparatus trying to deal with, the fact that the boat's moving and your eyes aren't really like noticing the movement, and that kind of that disconnect there. That's really what causes a lot of that nausea and vomiting there. Kind of similar to like like VR. I don't know if anyone's really mess with it too much, but when you have that disconnect between what your eyes are seeing and then what your body's feeling, that's where you get a lot of that. So antimuscarinics are good for that. But remember, a lot of the side effects, right? You're going to see things like dry mouth. You're going to see that blurred vision, urinary retention, etc. They also tend to be somewhat sedating, which is not good when you're going on a cruise and you want to be having fun. You don't want to be necessarily just asleep the whole time, right? So something to consider. Some other agents that fall in this category that also have some antihistaminic activity include things like dimenhydrinate, which is Dramamine. We have things like meclizine, which is antivert, hydroxyzine, and then diphenhydramine is always a good go-to there. But remember, these typically are going to be very sedating, right? Not always. Some people actually get a little excited when dealing with some of these medications there. So for instance, you'll have some kids who will have like a paradoxical reaction. They'll get kind of overexcited when they receive something like Benadryl, but it's going to be more on a case-by-case basis. Typically, it's going to be pretty sedating for the most part. Again, some of these are available over the counter, which is great. But again, you have to ask your patient, hey, what are you taking? Do you get without a prescription? Otherwise, it may not be all that to tell you, right? So Benadryl you can get over the counter, dimenhydrinate, meclizine, get all those over the counter. Something like hydroxyzine, they're actually only available via prescription. Is one thing, I'm not going to ask you that specifically on a test, but just kind of for your knowledge there. Scopolamine, also prescription product there. Yeah, also very good. Actually, one of the big things I've been doing with my daughter recently is that she has gotten a cold from her cousins. Happens every single time she goes and sees her cousin, she gets a cold. But she's having this, like, during the daytime, she's totally fine, not any issues, maybe a little bit of snot running down. But when she goes to sleep, she starts coughing like crazy. She wakes herself up, she wakes her sister up, she wakes us up. So what do you think I could do about that? What do you think is causing that cough? A lot of times it's postnasal drip. So what could I do to deal with that postnasal drip? I can get something to dry her out. So we tried Benadryl for a little bit. And again, I don't recommend drugging your kids unnecessarily, but we felt it was necessary in this case. Gave her some Benadryl to help dry her out. Benadryl didn't really work out so well, but we had some Dramamine in the house. We ended up trying that, and it worked a lot better because one, it helped her dry her out, decrease some of the coughing. However, what's the other big side effect of those drugs? Sedation, which is good because guess what? She's going to sleep. So even if she does start coughing, she may not wake herself up as well. Very nice, right? So again, 2 birds, 1 stone, and 1 sleepy, dried out toddler. It's great. Also, she may not wet the bed as well because, right, she has that urinary retention as well, right? So again, can get triple duty out of that. It's great. Anywho, moving on. Next, we have our antiserotonergic drugs. I really feel bad for my daughters if they ever go back through these videos and they're like, "Dad, you said what about us?" Anyway, so next up, we have kind of a workhorse sort of class of drugs. They're relatively new, and so we're still getting some information about safety and things like that. But for the most part, these are great, great drugs. They work very well, very safe for the most part. And these are going to be our antiserotonergic drugs, right? These are going to be our ones that are blocking the 5-HT3 receptor. Okay, this includes your ondansetron, which is going to be the kind of lion's share of use of the antiserotonergic drugs you're going to find. Zofran. You're going to have things like dilaceron and granisetron, so Antimet and Kytril. And again, this is nice because they're working not just centrally, like the antimuscarinics would do, but they also work peripherally as well. So they can work directly on the GI tract and also centrally try to prevent that nausea and vomiting, which is why they tend to be so effective. Not only are they very effective in things like chemotherapy-related nausea and vomiting, but we use it just basically for everything, right? Essentially, there should be just like a 55-gallon drum of like Zofran whenever you walk into the ER, and everyone just takes a hit off of that because everyone feels better after a little bit of Zofran, right? I think it's very, very safe for the most part and not a lot of issues. However, one thing I do want you to note is that you can't see QT prolongation. You think, oh no, QT prolongation. It's another thing I have to remember. Again, is it a problem in and of itself? If I were to give everyone in this room Zofran right now, is anyone likely to have torsades? Unlikely. Now again, do I say no one's going to have torsades? No, I can't predict the future. Unlikely to happen though, right? However, when does it become a problem? Well, when I'm starting to combine multiple meds together. So think about when these kids are getting, say, chemotherapy. Chemotherapy often causes what sort of kind of main life-threatening kind of problem? Immunosuppression, right? Okay, let's say they get a fungal infection, right? Now I got to put them on antifungal medications for that. So say I put them on voriconazole, that can prolong the QT. Say I have to put them on dansetron, that can prolong the QT. Say, for instance, they get bone marrow transplant for their leukemia. Now they're on, immunosuppressants for that can prolong the QT. When you start to add these things up is when you start to run into issues, right? So that's when you want to monitor. So does every single person get on dansetron in the ER going to get an EKG? Absolutely not, right? Not unless they have a history. They say, hey, oh, you have, history of congenital heart defects, or I got a heart transplant, or I have a, congenital prolonged QT, something like that. Or they say they're on a bunch of medications already prolong it. That's something you can consider, right? But for the most part, you don't need it, right? Because you may see a little bit of prolongation, but for most people, that's going to be within an acceptable range, right? And what's a normal QTC? Like 440, 450, somewhere around there. And again, why do you use QTC and not just QT? What's the difference? It's adjusted for heart rate, right? So again, the faster the heart rate, you'd assume that the QT would be shorter because there's less time in between the heartbeats, right? But using that formula, different ones out there, but the Bizet formula, for instance, it can correct it, right? So that is more of an apples to apples comparison based on heart rate. But anyway, so again, you may see a little bit of prolongation. It's not going to be a big issue for the majority of patients, right? But unless they tell you they have a high risk history, that's when you want to check it. If they're now, again, think about the dosing you're getting, right? So typical dosing for Zofran may be like 4 to 8 milligrams for your run-of-the-mill nausea and vomiting. For people getting chemotherapy, they may be getting like 16 milligrams. Getting repeated doses of it, that's where you want to start considering maybe monitoring from an EKG standpoint. That you're getting repeated doses, high doses, those are things you want to think about, right? So again, I wish I could tell you specifically, oh yeah, every single time you got to do this. It's not always the case, right? There's a lot of gray there, so you may do it in one type of patient, but maybe not in other patients. Kind of make sense? All right. What antibiotics should I worry about? The patient said, oh yeah, I'm on this antibiotic, and I give them Zofran. Maybe want to consider. Can you get? So macrolides, right? So azithromycin, erythromycin. What else? Fluoroquinolone is the other big one, right? Good. It's like you guys like retained something from past semester. It's fantastic. Up next, we have our anti-dopaminergic drugs. So before Zofran came along, we find that the anti-dopaminergics were kind of like our most potent agents that we had at the time, and so we use these quite frequently for things like chemotherapy-related nausea and vomiting. But there are some drawbacks to it. There's some definite severe toxicities you can see with high dose, long-term use of these drugs, and we'll talk about those in a second. But basically, they're anti-dopaminergic, which means they're blocking the D2 receptors. What other class of drugs have we seen that does that? Our antipsychotics, right? Predominantly our first generation antipsychotics. So we're going to see a lot of bleed over effects from that. The common ones you're going to run into include metoclopramide, which is Reglan, and you're going to find your phenothiazines, which includes things like prochlorperazine or compazine. This is a frequent one I see a lot of a lot of providers will order patients with migraine-related nausea, vomiting. They'll recommend prochlorperazine. Promethazine is another big one, right? Phenergan. I've already shared my experience with Phenergan. But again, what do you remember about these drugs? Sedation is a big thing, right? Because mainly due to their antimuscarinic activity. Okay. What else can you see? Based off the dopamine 2 blockade.
EPS, dystonia.
Yeah, so extrapyramidal effects can occur. Now, is it common? No, but think about those patients with chemotherapy that get high doses, repeated doses. That's when you want to start thinking about that. Or if you have multiple medications on board, they're both doing the same thing, right? So again, if I had someone who was on, say, Thorazine, and then they got a dose of Phenergan, that's where you can run into issues there, right? They're both being synergistic there. But also think about like the tardive dyskinesia, right? So again, people who are receiving this for chemotherapy long term, they end up developing tardive dyskinesia. Is that always reversible? Not always, right? So that was kind of a big deal because they developed this other effect that was due to our fault, right? Is iatrogenic there. So it's one thing to consider. Also think about things like increasing the prolactin level. This can be problematic, causing gynecomastia, could decrease fertility and things like that. And certainly there's a risk for neuroleptic malignant syndrome. Not common, but when do you see it more commonly? What agents? Haldol and flufenazine, right? Because those are the highest potency D2 blockers. So Haldol you're not going to see very often used as an antiemetic, but it can get some additional benefit by kind of pulling double duty in those cases. So if you need to give someone Haldol because they're maybe being agitated coming into the ER, maybe due to drug exposure, but they're also having nausea and vomiting, like perhaps that's a good double duty kind of drug there, right? You can get 2 birds with 1 stone, so to speak. So keep in mind they have the same sort of side effect profile as a lot of those first generation antipsychotics based on the dopamine 2 blockade. Okay. Next up, we have our cannabinoids. What do cannabinoids normally do for us? What do you like classically think of? Someone huffing a doobie. What do you think about? Where do they go to? The fridge. They get the munchies, right? They get very hungry. This is an appetite stimulant. Also has some antiemetic properties as well. So we'll talk about this a little bit more when we get into the pain management section. We'll talk about medical marijuana specifically, but these are agents we actually have. They're pharmaceutical products we have. You get a prescription for it that are used that basically work the same as medical marijuana. In fact, like dronabinol. It's a synthetic form of delta-9 tetrahydrocannabinol, or THC, right? THC is the main psychoactive component of marijuana. And we've been using this for years, right? So again, you talk about medical marijuana being a relatively new thing in the state of Florida, but we've been using cannabinoids for many, many years now, right? So again, we had something more synthetic. But people are like, we like the natural stuff, man. All right, cool. I mean, cyanide's natural, but whatever. But we do have these available too, right? So you can definitely try these. Now, do you think these are controlled substances? Absolutely, right? Because again, we worry about abuse potential. We worry about you do see some euphoria associated with these, so there's something to consider there, right? Now, on the grand scheme of things, is it as addictive as something like heroin? No, but again, it's the regulations put forth by the DEA, and so that's what we have to follow, right? So anyway, so these are oral formulations, and these are mainly used for nausea and vomiting associated with chemotherapy, right? So if you have someone coming into the ER, be like, I'm a little nauseous, can I get some of that? Can I get some of that Marinol? No, they're not going to get that, right? This is more for patients who have receiving chemotherapy. They're chronically, nauseous. They're vomiting a bunch. What do you think happens to their appetite when you're receiving chemotherapy? You don't want to eat, right? You're just sick all the time. You just don't want to eat, and then they develop, muscle wasting, and they just start losing weight. This is a good thing to help kind of stimulate the appetite, right? So that way they're going to have to deal with some of that nausea and vomiting if they also want to eat. That's going to be good. They can put on some weight again. And of course, think about, normal side effects you'd expect to see if someone who is exposed to THC. You can have some mental slowing, there could be some ataxia. In some rare cases, people have, some bad reactions to it. They'll have, some paranoia, hallucinations, relatively rare though, right? But again, imagine you're prescribing this to a patient, they're taking it home. What do you want to tell them as far as the education goes? What should they not be doing? They shouldn't be drinking with it, because again, you can see some synergistic effects there. What else? Perhaps not go driving, right? Because again, they're under the influence, right? So again, if they get into a car wreck because they're taking their Marinol and they had some mental slowing, or they weren't, being all that perceptive of what was going on around them, and you never told them to not go driving, which, the pharmacy is going to put labels all over it, says not to do that. But you can see how they kind of, some laid this down from a litigation standpoint. Well, I was never educated. This is going to, I never knew this was like basically pot and a pill, and, that it's going to cause some problems. So things you want to consider, right? Educating patients effectively. All right, up next we have our substance P antagonist. And so substance P, what do you normally think about substance P? You guys ever heard of it before?
Fibromyalgia.
Fibromyalgia, what about it with fibromyalgia?
A lot of substance P.
Yeah, so, and again, this is good because we're talking about chili, right? So we're talking about spicy stuff. Substance P is a mediator of spiciness. So you can find that substance P is also a mediator of pain. A lot of nociceptive nerve fibers release substance P. One of the things we also find is that substance P can cause nausea and vomiting, right? Especially more centrally. And so this is going to be a class of drugs, and we'll talk about substance P in terms of like neuropathic pain later on in the pain management section, but for our purposes right now, basically we have this drug called aprepitant. It's going to be working as an antagonist to substance P at this NK1 receptor. And so basically what this does is it helps to deal with very severe nausea and vomiting. Most often this is going to be used mainly just in chemotherapy-related nausea and vomiting. What's interesting is that with some of these really severe metagenic drugs, especially like cisplatin, you're going to find there's kind of the acute nausea and vomiting phase, but they also have this kind of delayed phase that occurs maybe 36 to 72 hours. So even though they haven't received the drug in, say, a day and a half, they can still get the very severe nausea and vomiting associated with it. And again, with cisplatin, virtually every single patient is going to is going to be vomiting if they don't receive drugs, but many patients get this delayed phase as well. And they find this is actually very effective by blocking substance P, and then for the 2 days afterwards, alongside with the chemo, you're going to find this able to deal with that delayed phase. So very good for that. It is a CYP3A4 inhibitor. Do you want to be careful? Make sure you're adjusting the drug dosages based if they have it. I'm sorry, this is just a yeah. So this is going to be inhibiting CYP3A4, so be aware of that. But it also induces CYP2C9. So just check your interactions beforehand. Make sure you're not going to find any issues there, right? What are some other agents we can use? We have our corticosteroids. So corticosteroids, and again, what are some agents that fall into that category? So 2 on the slide. So prednisone, dexamethasone. What else? Methylprednisolone is a good IV agent, right? What else? Prednisolone, which is the active form of prednisone, is also the liquid form that we have. What else? Hydrocortisone could also be considered in this category too, right? So again, that's different options we have available to us. But more common ones you're going to run into include dexamethasone and prednisone. And oftentimes this gets used for nausea and vomiting related to chemo as well, right? So again, we're already seeing there's a lot of different drugs you have to use along with chemo-related nausea and vomiting. But one of the things you can also consider too is that, what does, say, for instance, Decadron effect have on the immune system? Corticosteroids are immunosuppressive, right? So again, what kind of cancers do you think it might be good for? Perhaps leukemias, where the immune system is rapidly dividing unchecked, right? So this is sometimes where you can find that corticosteroids can be a part of the actual treatment for the cancer. Namely, this is some forms of leukemia, you can find this, but also be used as an antiemetic as well. So sometimes you'll find it kind of pulling double duty, sometimes it's just used for one or the other, as the case may be there. So again, that's where you're most often going to see this. Again, most patients coming in off the street with gastritis, normal run-of-the-mill nausea, vomit, they're not going to be getting corticosteroids. They're not going to be getting substance P antagonists. This is more of those big guns you're going to need for chemo-related nausea and vomiting, right? Most of the time, Zofran is going to be good for most patients. Phenergan is going to be good for most patients. Things like that are going to be kind of your workhorse sort of drugs. And then similarly, benzos are going to be better for that anxiolytic sort of purpose prior to getting chemotherapy. So we'll give them, say, for instance, Ativan, say, an hour or 30 minutes before they're getting their chemotherapy to help kind of deal with that anticipatory nausea, vomiting. Lorazepam is good because that's IV, available IV, so we can administer that way. Alprazolam, Xanax is an oral agent. So any of the benzos could work though. These are just some examples of ones you're going to see maybe more commonly. Okay, so choosing your antiemetic, we have a whole potpourri of different options that are out there. It should be tailored based on the specific patient situation, right? So for instance, if they say, I'm really nauseous, but man, I got to go sit through 8 hours of classes tomorrow at my PA school, what should I consider giving? Kind of the secret is like Zofran's probably the answer to like any patient, right? Unless they have like QT prolongation already. But say for instance they're like, man, I'm so nauseous, I can't go to sleep. What could be a good option? Reglan, Phenergan, like so. Think about things like whether they're sedating or not is going to be kind of a big determinant on which ones you're going to choose. If they failed Zofran, certainly can go on to one of the phenothiazines, such as prochlorperazine. You can use promethazine. Any of those are fine. But think about whether the patient's in a state where they can risk getting sedated or not. If they're going to be homesick for a couple days, they just need to sleep it off. Like that's totally fine. Use a sedating agent. But if they got to go to school the next day, they got to go to work, they're driving a truck for a living, anything like that, like use a non-sedating agent. Zofran's really good for that, right? Again, Zofran's probably the workhorse out of that group of antiserotonergic drugs. The other two are more used for chemo-related sort of nausea and vomiting. So, and as I mentioned, think about the route. Or, if people are actively vomiting, can they necessarily swallow things? Not necessarily. So, what are some other routes that I could use? I could use the rectal route. Now, again, do patients usually like the rectal route? You walk in a room, put on your glove, and say, take down your pants. Like they're not going to be too excited, right? So again, it's one of those things where the route is very important, but rectal route for things like promethazine, awesome. We can use that if we need to, right? The IV route is also available for a lot of these. So we have IV Zofran, we have IV Phenergan, we have different options that are available there. But also, what are some ways we could do it? Maybe not orally, we have to swallow something, but we can still have maybe buccal absorption. We have the ODTs, which stands for oral disintegrating tablets, right? So that's another good option as well. They can just kind of put it underneath their tongue, it'll dissolve, absorb there. So it's a very good route for things like Zofran. We have good options there, right? And then just think about, if they're going on a cruise or something, they're going to be using that transderm scope, they need to use it a few days beforehand, right? Because otherwise it's not going to be working. Something like Dramamine, one of these antimuscarinics, they can take it while they're on the cruise, and that's going to be totally fine. They're going to get that effect there pretty quickly, but the transdermal is going to take a few days to kick in. Okay. All right. Up next, we have what we consider to be our prokinetic drugs. What do you think these do? They move things along. They stimulate peristalsis. They're going to be able to be used for patients who maybe have say for instance, gastroparesis due to diabetes. If you have any kind of GI motility issues, these are going to be good to help kind of stimulate movement along. So we have a couple different agents here. One of the big ones is going to be metoclopramide or Reglan. So we already saw this before, right? We used it as an antiemetic previously. Basically what it's going to be doing is trying to stimulate gastric emptying. It's going to be stimulating the upper GI motility and increasing the upper or lower esophageal sphincter tone, which again is good because you don't want to have that retrograde movement of food back up the esophagus. So basically trying to close that down and kind of force everything along this way. So as you might imagine, what could be a potential side effect from that? Diarrhea could be a potential, right? So again, think about the actions, think about what's going to be happening there. And again, all the same side effects still apply to this, whether it's being used as a prokinetic or this used as an antiemetic. And again, imagine if you had a bunch of food sitting there in the stomach that's not getting passed along, what could be a potential effect of that? You're going to vomit it up, right? So again, this is good that Reglan can kind of provide double duty there as an antiemetic and also stimulating things to move on down the GI tract, right? So some things to think about. And then we have erythromycin. You say, wait a second, erythromycin is antibiotic. I will tell you, at least from a ped standpoint, we use way more erythromycin as a prokinetic agent than we ever use it as a anti-infective agent. Maybe like ophthalmically we'll use it sometimes, but never for an infection, right? Because more often, what are we normally using from a macrolide standpoint? Azithromycin. We also have clarithromycin. Those are two of the more common ones you're going to run into, right? Again, mostly just azithro for the lion's share of that. But anyway, so again, this is going to be good because erythromycin, as we saw, if you think back to your anti-infective lecture, is that it causes diarrhea, right? Because it actually has activity on these motilin receptors. It's going to stimulate those, now stimulate peristalsis and cause diarrhea, can cause cramping. But again, if it's moving things along, that's what your patient needs. That's going to be good. So we have a lot of patients end up getting erythromycin just due to that kind of slow GI motility there. Okay, up next, we have our laxatives. So what kind of drugs do you think fit in this category? No ideas? Synecot's going to be a good one, right? We'll talk about what Synecot is in a little bit. There are going to be different classes of laxatives we're going to have here. Anyone like never taken a laxative in your entire life? Or seen people like taking like fiber supplements or Miralax or anything like that?
Go lightly.
Go lightly. Is there any chance that anyone has ever gone lightly on Go Lightly? Nope. We'll talk about why that is in a minute. Well, go heavily, because that's what you're going to do. Anyway, so what are some common causes of constipation, right? So obviously we have some different disease states that can be affecting this, certainly things like hypercalcemia. We talked about calcium carbonate. What was the main thing that caused? Causes constipation, right? Anything with calcium is going to cause constipation typically, right? Obviously there's a lot of behavioral issues that could be playing a role here, but looking at drug-induced causes, because again, this is a very frequent thing. You're going to find that oftentimes patients are going to complain of constipation. Your first question should be, what medications do you take? Well, maybe some other questions too, but again, from my perspective, I say, what medications are you taking? Because very frequently you're going to find that patients will have drug-induced constipation what do you treat with? More drugs, when really the answer could be get them off of those drugs in the first place, right? That would be ideal, may not always be the case, as you'll see. But number one drugs that are going to cause constipation are opioids. Opioids. It's hard to say 3 times fast, but always are going to cause constipation. It's a very common, very expected sort of side effect of opioids. We'll talk about those much more in detail, I believe, in the next section, but it's good to know that's going to be one of the main causes of that. Anticholinergics, as we mentioned, right? Antimuscarinic specifically, because they're blocking peristalsis. And again, this is one of the things that we look at, say, from a toxicology standpoint. If a patient coming in to the ER and they are found down, unknown exposure, one of the things we listen to is the bowel sounds. Why do you think we do that? If I can't hear them, then that probably tells me that something's slowing them down. Well, what could be some common things that slow down the GI tract? Well, opioids. It's a common thing people overdose on. Anticholinergic. We've covered a gazillion drugs that have anticholinergic properties that can lead to that, right? So those are things that help me with my differential to be like, okay, well, they had really hyperactive bowel sounds. Maybe probably unlikely to be something like an opioid. It's unlikely to be something like an anticholinergic, right? Because normally that would slow it down. That helps me with my differential. Also as well, imagine if someone was taking opioids, their GI tract is slowed down, they just take a big overdose, they took 100 tablets of Percocet or something. Is that going to be moving nice along through the GI tract? No. It's going to be sitting right there. So I have to worry about things like delayed absorption of medications too a little bit later on once the guts start to wake up a little bit. So little things you have to think about from that standpoint. But let's focus on other things that can cause constipation. We talked about some antacids that can do that, like our aluminum hydroxide is a big one. Iron is another big one as well. So iron sulfate, and again, a lot of patients are taking this just as a normal supplement. And then things like calcium channel blockers. Now, why would you think calcium channel blockers would cause constipation? Because basically the GI tract is just surrounded by a bunch of what kind of muscle? Smooth muscle, right? Smooth muscle is really dependent on what for normal function? Calcium, right? So if I'm blocking the influx and the outflux of calcium there, you can see how that can disrupt that normal peristalsis, right? So things like amlodipine, things like verapamil, all that can cause constipation. Is a big side effect there, and we talked about that. We covered those drugs previously, right? So again, a lot of different drugs are there. If your patient's complaining constipation, go over the med list and figure out if something there could be playing a role, right? But what's our goal here? Obviously, we want to relieve symptoms, hopefully reestablish normal bowel habits, and then increase the quality of life. And again, most of the time, especially just speaking from a PTR sort of standpoint, people presenting with abdominal pain, what is it 9 times out of 10? They're constipated. Usually they're constipated. I ever tell you the story? My cousin called me, his daughter, she was like 4 at the time, and he goes, oh my gosh, I'm taking her to the ER. She's in the worst pain she's ever been in her entire life. I think she's going to die. She's going to die. Oh my gosh. I'm like, she's constipated. He's like, no, there's no way. She's in so much pain. And then 2 hours later, he calls me up. He's like, how'd you know? And I was just like, I work at a PTR. I see this all the time, right? They get an enema, clear all that bowel out, or the stool out, and then guess what? Right as rain. Immediately, all that nice pain goes immediately away. It's fantastic. But so what can we do, right? What can we do to try to increase that defecation, try to get rid of all that stool? A couple of different things. One, we can try to directly stimulate motility. Certainly we saw things like prokinetic agents like erythromycin and metoclopramide can be useful for that. That's not really going to be good for acute defecation, right? That's not really going to be fitting our role here. It's more for kind of more chronic use. But we'll find some drugs that increase motility. We'll find things that increase the water content of the stool. What do you think that helps with? You have this like thick, dry stool. I always talk about like my kids, like they come out the rabbit pellets. Like they don't have enough water, right? You just know they're dehydrated. So, and again, it doesn't say we're bad parents. It's just like they get active and they're playing and they don't want to drink and things like that. But they get this little hard rabbit pellets, not easy to pass, right? So if I can do things to try to emulsify the stool, make it a little bit easier to pass, that's going to be much more easy for them. They don't strain as hard. That's gonna be good, right? So that's one thing we can do. And then we can also try doing things like decreasing the reabsorption of water and salt within the colon. What do you think that's going to do for us? By increasing the amount of water and salt in the colon there, that stretch happens. What does that stretch do? It says we got a bunch of stuff here. We got to move it on out, right? So it stimulates peristalsis, right? It stimulates defecation. And so we're going to find there's going to be things that we're using to try to draw more water into the stool and things to try to use to try to block the absorption of water from the colon, right? We're going to look at some different options there. Anyway, what are some indications? Why might we be deciding to use laxatives for our patients? Certainly things like prep for bowel, prepping the bowel for surgery, or say they're getting a colonoscopy or something like that. Little things like using Go Lightly to try to clean out the GI tract. I recently saw a story on Reddit that said that I think like Martin Short, Steve Martin, and Tom Hanks, they all do Go Lightly together the night before they go for their colonoscopies. I thought it sounds like a very fun time. 3 comedians all getting anyway. But yes, that's one thing we can use it for. Sometimes we use it to hasten the excretion of toxins from the bowel. So if I have something like a lithium overdose, lithium is something that does not get absorbed to something like charcoal very easily. So I have to give something like Go Lightly to force it out of the GI tract before it gets absorbed. Things like postoperative bowel stimulation. If you have patients who are you don't want them to strain so hard because of cardiovascular disease or something. That could be another indication. Lots of different reasons here. Be careful though if you have underlying bowel disease like inflammatory bowel disease. You want to avoid these meds because that can then potentially aggravate that. Generally, what kind of side effects would you expect from laxatives? You feel like you have to go to the bathroom, right? So you have cramping, you have abdominal pain associated with that, diarrhea. Obviously, if you kind of overdo it. So be careful, and again, depending on which kind of route we're shooting for, diarrhea may be pretty commonly seen with that. And then chronically, this is more of the big issue we worry about. You don't want patients to be chronically on laxatives for the most part, right? There's some that you can be on every single day, you're not gonna have any issues, but you get what is called cathartic colon syndrome. Again, that's the name of one of my metal bands in college, but what happens is you get this mucosal inflammation, you have this atrophy of the outer muscles, because again, if the muscles aren't being used, they're not being stimulated because you're having this laxative come along that kind of does all the work for you, that muscle doesn't get used and it atrophies, right? So you find that the patients become very dependent, become physically dependent on these laxatives in order to have a normal bowel movement. Now again, is that addiction? No, it's a physical dependence, right? So again, just like with any other class of drugs, like opioids or something like that, physical dependence is very different. But again, they become very dependent on these. Okay? They have issues where they're losing protein, they have malabsorption, etc. So again, be very careful with this and try to use laxatives as for short a course as possible. And again, some of these are available over the counter, so people can be abusing these on their own without any of your knowledge and can run into some of these issues here. So kind of 3 categories as we mentioned. Things are going to soften the feces, about 1 to 3 days or so. We're going to look at our bulk forming agents. We're going to be looking at our emollients and then some osmotic agents. What do you think those osmotic agents are going to do? Going to draw water into the GI tract, into the colon, right? We're going to find things that are going to result in kind of soft or kind of semi-fluid stool within 6 to 12 hours. These are going to be where we come into our stimulant laxatives. We talk about opioids, I'll talk about mush and push. When it comes to laxatives, this is the push, right? This is the stimulant thing that will directly stimulate the GI tract to cause defecation. And then there are things that can cause a watery evacuation that you never want to think about when it comes to stools, but within 1 to 6 hours, right, is where we can use high doses of our osmotic laxatives, where like your Go Lightly's come into play. We can use things like enemas, which can be very effective. We'll talk about some different options there, and then things like bowel cleanouts. It kind of goes along with the Go Lightly there. Okay. So looking at our bulk forming, these are kind of like the most benign out of the bunch. Like you're not going to find patients really developing a whole lot of physical dependence on these sort of agents here. And again, they're just in general, you want to get good fiber in your diet, right? So again, this can be supplanted if you have a nice well-rounded diet, you're getting some nice roughage in there. But sometimes we need additional supplementation. So this is where you have things like your psyllium husk, like your Metamucil, you have things like your methylcellulose, all of that. Now, has anyone ever taken like Metamucil or any of these other products? Maybe grandma was taking them or something like that. What do they look like? What do they come as? this powder, right? So it's this, because again, it's a bulk forming agent. Like it's usually a decent amount of powder. It's a big heaping, teaspoon or tablespoon full of powder. It's not great from like a compliance standpoint because again, it's very kind of gritty and patients don't really like it that much. So this is one of the problems you can run into where from a compliance standpoint, it's just not very palatable. And also as well, you may find they can actually bind up other drugs and may prevent absorption there. So again, if the drug's going to potentially bind with something like a bulk forming laxative, use the medication a couple hours beforehand, maybe like 30 minutes an hour beforehand, or give it a couple hours after they receive the bulk forming agent, right? So that way you try to prevent any drug absorption from happening there. And obviously flatulence cramps are going to be pretty common side effects seen with that. Again, just by increasing that volume, increasing that bulk there, you're going to find that's going to be stimulating that stretch receptors and going to cause defecation to occur. Up next, we have our stool softeners. And so these are going to be things that are going to be used to try to emulsify the stool to try to make it a little bit easier to pass. So instead of those little hard rabbit pellets, you're going to be able to get a nice, better formed stool. You guys have seen like the stool chart before. What's that chart called? It's the Bristol stool chart, right? They talk about it. Again, the descriptions are just not great. But it could be good for when you're trying to describe it to your patient. What are your stools like, Again, just like we were talking about with when you're in the grand rounds, like, what's the color, what's the consistency like? Sometimes you got to get a little graphic to get a good idea for what's going on there, right? Because again, you say, hey, do you have melena? I have no idea what the heck that is, but do you have black, tarry, tenacious kind of stool? Like that one may paint a better word picture for them. But things like mineral oil can be used here, things like glycerin, all very good emulsifying sort of agents there, kind of lubricating up the stool so it's easier to pass. Docusate's another big one. This is a very common one you can either see given rectally, given orally. Interestingly, you can also use this in the ear. And we've never seen Docusate being used in the ear. So you may see this occasionally. You may use this occasionally. One of the things you may find is also it helps emulsify cerumen. So if you have someone who has some impacted cerumen in their ear, coming complaining hearing loss, you can actually use some Docusate in the ear. That'll loosen that up, and then you can irrigate it out, and then all of a sudden have their hearing back. So one thing you may see used off-label. Anyway, but again, by kind of increasing that water content, lubricating, it's going to be much easier to pass. We're not going to have to strain as hard. That can be very useful. When I say the mush and mush and push, this is what I'm talking about. All right, so these are the emulsifiers. And then I mentioned the stimulants here. Here's the push. These are things that typically will directly stimulate, they'll irritate the colon to try to stimulate defecation here. So these are things like castor oil, which is not honestly used all that too frequently anymore. It's kind of more like a home remedy kind of thing. But the things we do use very frequently are senna and bisacodyl. Bisacodyl. Either of those are going to be able to stimulate that colonic motility. Oftentimes they're used in combination with a stool softener. So if you ever see like Docusate plus senna, that's something you see pretty commonly there. By using the combination, they get better synergy than with either one by itself. You're going to see a lot of cramping with this, a lot of diarrhea, muscle weakness potentially with this, because again, it's going to be a very powerful stimulant to defecate. This is where you really want to use it for as short a time frame as possible. If you think back to when we were talking about ENT stuff, we talked about using Afrin for like stuffy nasal passages. What was the thing that you saw with that? Thing you wanted to remember? You don't want to use it within more than a couple of days, right? More than 5 days or so, because what do you end up getting? The rhinitis medicamentosa, you get that rebound nasal stuffiness, right? It's probably more severe than what's happened beforehand. Same thing happens with this, right? So again, if they become dependent on having that stimulant around to try to defecate and you take it away, they're going to find this rebound constipation. That's where you get this toxic megacolon that can develop potentially, that cathartic colon syndrome, most commonly seen with these stimulant drugs. So again, try to recommend using these for as short a course as possible. However, if they're available over the counter, you can get a lot of these available. Just go to the Walmart, go to the CVS, Walgreens, and they can be treating them themselves, no problem, right? What kind of people do you think might actually abuse laxatives? Yeah, they're using it for like weight loss, right? So they have like any kind of eating disorders where they're trying to lose weight. They can potentially use laxatives to try to stimulate things along to lose that weight. Up next we have our osmotic agents, and so these are basically trying to draw water into the colon to try to increase that bulk, to try to increase that stretch in the colon there, to try to stimulate things along. And so this is where we saw things like our mag hydroxide before could be considered one of these. It's that milk of magnesia we mentioned. Mag sulfate is used occasionally, lactulose, mannitol. Anyone know where else you see lactulose being used? Used in liver patients for ammonia. So if you have someone who has hyperammonemia, secondary to like liver failure, cirrhosis, things like that, they will oftentimes get lactulose. But one of the big side effects of that lactulose is what? Diarrhea. So oftentimes you're having to adjust their dose based off of the defecation have too severe diarrhea, it's not going to be good for them. You know, I want them to remain continent. So again, sometimes you have to kind of balance things out between the therapeutic effects and the toxic effects. And lactose is a good example of that. You can certainly use it in patients without hyperammonemia, but it's something that you can see used occasionally. This is also where we get our sodium phosphate enemas. These are our fleets enema, very fleet. That's what we're referring to there. Now, fleet enemas you have to be very careful with because that phosphate is not benign, and so you're going to find that, especially depending on the patient, usually of extremes of age, so the very young or the very old, they cannot handle that extra phosphate. Because what's going to happen is they're going to absorb that and get hyperphosphatemia, and there's been deaths associated with this before. So be very careful. You know, this is more seen with like repeated uses, or if they have like renal failure and they're older. Those are the patients you want to be really careful with. But you know, whenever we have kids that are coming into the ER complaining of abdominal pain, they think they're constipated, we'll ask them, what have you already tried? They say, oh, you know, try a glycerin enema or a glycerin suppository, nothing happened. Okay, that's fine. We can try giving an enema and see if that works. However, they're like, oh yeah, we already tried a fleet enema at home, and they're, you know, say 6 months, a year old. That's probably something I'm not going to try to re-challenge them because I worry about their phosphate levels, worry about causing dysrhythmias, etc. So again, people have died from that. So be very careful with fleet enema. Then we have a polyethylene glycol. So normal, like typical, like oral usage of this, you can either find it used kind of every single day for kind of prevention of constipation. That's where you get your Miralax, where they're taking like a capful per day. That's usually what you see with that. That's one they can have every single day. It's kind of like the psyllium husk or the bulk forming. It's totally fine from that standpoint. When you need a bowel clean out, you need to get rid of absolutely everything in the GI tract. One of those fire sales, or say we gotta get rid of everything. Everything must go. That's where Go Lightly comes into play, right? Now again, why do you think they spell lightly wrong there? Electrolyte, absolutely. So anytime you see LYTE, it's usually due to electrolyte. So that's the thing with Miralax, is that it's balanced such that you're not going to see any disruption of their sodium or their phosphate or anything like that, because it's balanced between what's in the blood and what's going to be in the colon there. So it's nice because you're not going to find any kind of electrolyte disturbances like you could see with something like a sodium phosphate enema. Okay, that's why they call it Go Lightly like that. But again, anyone ever seen a Go Lightly container? It's a big 4-liter jug they're going to get. It's got powder in it. It's the polyethylene glycol. You fill it all the way up to 4 liters and say, here, drink all of this. And anyone know what it tastes like?
Garbage.
It's got all this electrolytes in it. So it's been described to me, I've never taken it, but it's described to me as warm sweat. Right? Yeah, it sounds terrible. Sweat's salty, right? And that's what they put into electrolytes. But so again, not great from a compliance standpoint. Usually patients will have several hours that they need to, over the course of a day, they can be drinking this. But again, the idea is to try to clean out the entire GI tract. So that way, if you need to go into scope or if you need to perform surgery or anything like that, it's cleaned out, right? Now, again, one of the things you need to consider is like, well, what color is Go Lightly? It's clear. Why can't you make it like fruit red punch? Yeah, exactly. So imagine you're going with a scope and you see a bunch of red stuff everywhere. You're going to think it's blood, right? So these are things you have to consider, right? So, ask them, were they really NPO, or like what were they drinking beforehand? If they're like, oh yeah, I had a bunch of Kool-Aid before I came in, like not great, right? So just things to think about. Now, one of the things we'll do for instance, we have a patient who had overdosed on something like lithium. They come in. Now, overdose patients are trying to harm themselves. Do you think they're very receptive to our life-saving attempts? Oftentimes they are not. Sometimes it's a cry for help and they're totally fine with it. But sometimes they're like, no, I'm trying to kill myself. Stop doing whatever you're doing to me, right? And so do you think they're going to just calmly drink this 4 liters of Go Lightly very easily? No, sometimes we have to use a little bit of some force there. So what we do is we actually can put an NG tube, and some patients just can't drink the Go Lightly on their own anyway, even if they're using it for a normal bowel prep, like kids can't. You do it in a lot of cases. We'll just put an NG tube down, and actually you can run that that way. So you can run pretty high amounts. Sometimes we're doing like up to 2 liters an hour. Imagine drinking anything 2 liters an hour. Not great, right? You're gonna have a lot of defecation. You're gonna have a lot of bloating, a lot of cramping, same with that. But we'll do it, right? And that will help to flush out things like lithium out of the GI tract. So, and again, sometimes we'll actually do what we call Go Darkly. We'll actually give charcoal before the Go Lightly. The benefit of that charcoal, you can use it as one. It can help to bind up drugs that are in the GI tract, because again, most people when they overdose on something, they use multiple substances at the same time. So we'll use that to bind up any other drug that's there. And then we can also use it as a tracer, so that way when they are on the bedside commode and they're actually defecating, we can see, okay, once the charcoal starts to come out, then we know we're kind of going through and we're getting rid of the stuff that was there at the time, right? So that can be sometimes useful from that standpoint. Anyway, Yes, Miralax is good for everyday sort of use there, but if you need the really big doses, that's going to be for more of the bowel clean out. So the go lightly when we talk about that. Be careful if you have a neutropenic patient, as we mentioned. What's the problem with the neutropenic patients in rectal administration? Yeah, tissue's friable, right? It's going to be more delicate, and if you cause any sort of damage to that, you can have translocation of gut flora, gut bacteria, and guess what? Then you see infection, right? Be careful with that. As I mentioned with the electrolytes, be very careful in the older patients and the very young patients because that hyperphosphatemia can be problematic. Any questions from the first half? Did you guys hear that there was a recent article I read? I was reading up for this topic, and they found a genetic link to certain causes of diarrhea. So that runs in your genes. Anyway. Thank you. All right. So remember, when evaluating these patients with constipation, it's got to be very treatment, patient specific, right? So you can kind of figure out what the underlying etiology is. Obviously, if it's more of a psychological sort of issue, which can happen with some, especially children, if they have kind of a little more chronic constipation, they have a lot of pain, they get a lot of anxiety and fear associated with that. Maybe something like an anxiolytic might be okay, in some of those cases. So it needs to be pretty well tailored to your patient there. Obviously, most people could probably do with more fiber and water in their diet. Most people tend to be kind of chronically dehydrated, and just more fiber is always better, right? Now, for the most part, if you're just kind of run-of-the-mill, kind of intermittent sort of constipation, osmotic laxative or an emollient, something like that can be very beneficial. Some docusate, maybe some Miralax, those are totally fine. Try that for a couple of weeks and see how it goes, right? If no relief, no bowel movements for 2 days or so, that's when you can start to think about a stimulant, but really try to use short courses for that whenever possible. And then if we have patients who are on opioids, we'll talk about this in the next section coming up, but there are actually some opioid antagonists. And when you think opioid antagonists, anyone know a good one? Narcan, think about that. Narcan has some problems because it puts patients into withdrawal. We actually have some agents that work just on the GI tract opioid receptors and actually don't cross into the CNS. So we'll talk about some examples about that a little bit later. But and then if you need an acute sort of evacuation of the bowels, this is where osmotic agents are going to be most beneficial. So this is where you're going to be using things like mineral oil enemas. You can use sodium phosphate enemas. You can use Go Lightly. Any of these options are going to be available to you, right? Okay, so we have a couple of antidiarrheal agents. Now, what's kind of the caveat with antidiarrheal agents? What do you think about that? Or what if they have diarrhea from like an infectious cause? Do you necessarily want them to be holding on to that? Not necessarily, right? So use these sparingly, right? Especially if you think it's more infectious related, probably avoid them in general, right? Sometimes it's okay just to try to get rid of that as long as they still have good PO intake and they're able to stay hydrated and all that good stuff, right? But what you're going to find is that typically our agents that we use as an antidiarrheals typically are working on the GI tract, on the opioid receptors, but these are agents that you would think could cause opioid effects. However, what you find is they cannot cross the blood-brain barrier. If you remember, we were talking about things that can cross and can't cross. What was the thing that usually prevented drugs from getting over? Usually having either like a very large molecule or something that's very hydrophilic. Usually most of these have a positive charge on them. They have a permanent positive charge. And so diphenoxylate, loperamide actually can't get across, and so they are able to give you the nice decrease in peristalsis, decrease in diarrhea, but they don't cause the typical opioid sort of euphoria. That doesn't mean people have not tried. People have tried using things like crushing up and injecting some of these products. And so if you ever see diphenoxylate or low-modal, typically you see it with atropine. Atropine itself does not get absorbed very well from the GI tract. And anyone know what atropine does? It's an antimuscarinic. Typically, when you see it being used, it's like in the emergency medicine setting or ICU setting where you're trying to increase heart rate. This is an antimuscarinic, right? Because it'll block the vagal or those vagal effects on the heart. But one of the other things you find is that antimuscarinics, especially when used IV in very big doses, makes you feel pretty crummy. Like it's some people try to abuse anticholinergics for a high, but it's a pretty crummy high from what I hear. So what they tried to do was they said, well, let's try to deter abuse. If someone tries to crush up this diphenoxylate, we'll then inject it. We'll put atropine along with it, so that way they feel so bad afterwards they never try that again. Who knows if that's really that effective? I've not really seen anyone ever try to abuse diphenoxylate before. Loperamide, on the other hand, is actually kind of interesting. So one of the things that, the reasons why loperamide cannot cross the blood-brain barrier is because it has, remember that PGP protein we talked about? It's an efflux pump. It can either be located in the GI tract where it kind of shuttles things out of the system back into the GI tract. Well, we have them on the blood-brain barrier too. They can shuttle things out of the CNS back out to the normal bloodstream, and they prevent that crossing from occurring there. Loperamide normally undergoes that. We talked about with the H2 blockers, which one do we say we're never ever going to recommend? Cimetidine, but why? It's a CYP3A4 inhibitor. It's also a PGP inhibitor. And so I've actually had some patients, a couple of case reports. I've seen one case of this where this lady had must have Googled it and found this online, but basically said, well, what if I take a drug that inhibits that PGP and take a ton of loperamide and have it cross the blood-brain barrier, and then you can get high off of that? Because again, those agents are available over the counter. You can buy a ton of it without anyone really batting an eye, and ended up in torsades, ended up intubated for a week or so. A very, very bad case there, but again, sometimes people will try to use some kinetic sort of interactions to their advantage, and again, this is not really to her advantage because it turned out pretty bad. She lived in the end though, which is great. Obviously, like you might expect, giving an anti-diarrheal is going to lead to constipation, right? So again, that's one of the big effects you're going to expect to see with that, okay? We also have bismuth subsalicylate. We mentioned this previously in terms of being used as a GI protectant. We talked about it being used in H. pylori. It also has some antidiarrheal properties as well. So this is good by helping to inhibit some of those intestinal secretions. Pretty effective for infectious diarrheas as well, right? And again, having that aspirin in there as well helps it kind of be sort of an anti-inflammatory additionally. But just be aware, like the raised risk with the salicylates, getting too much bismuth. Holding on to that, especially patient with renal dysfunction, can have some toxicity associated with it. So just be aware of that. You don't want patients using this, too often. Okay. So any questions on diarrhea, laxatives, constipation, any of that stuff? Fantastic. Well, let's move into the last section here. Is going to be inflammatory bowel disease, and we'll talk about irritable bowel syndrome as well. So IBD and IBS. Now, what is IBD? Inflammatory bowel disease. At its core, it's an autoimmune issue, right? So you guys started rheumatology already? You're going to see some crossover between some of the medications you're going to see in rheumatology and what you're going to be seeing here. And when we talk about rheum, I think it's actually in this section as well. So you're going to see some bleed over some of those drugs, which is nice. The two main delineations are going to be ulcerative colitis, and we also have Crohn's disease. Okay, what's kind of the big difference between the two? Ulcerative colitis is mostly located in the colon, right? And Crohn's disease is going to be what? More interspersed, right? It's going to be more kind of, dispersed throughout the GI tract. The reason why I make this point here is because this is actually going to help us to determine what type of drugs we can use, and also what routes we can use, right? So for instance, if someone only has, say, a very distal sort of ulcerative colitis where it's really only affecting, say, the distal portions of the colon, well, sometimes we can actually use rectal medications just to get that one area of the colon affected, versus if it's more diffuse and it's affecting the entire colon, might need to use more oral options. Okay, so we're going to see some different options there as we go forward, and we'll look at and see what's going to be most appropriate. And so based on how the patient is presenting, based on what the findings are, may lead you to choose more oral options, IV options, rectal options, as the case may be, right? Anyway, so again, this is going to be basically this inappropriate immune response. And so this is where we're going to see a lot of monoclonal antibodies are going to be used here. We're going to see a lot of disease-modifying drugs are going to be used here. They're going to help to slow down the progression of disease. But we're also going to find that we have to deal with these exacerbations that occur as well. And so again, what have we talked about when you have these kind of inflammatory exacerbations? What's a good drug to use? Say for you have like an MS patient, right? That's another autoimmune condition where what happens when they have a flare-up? What do you give them? Give them steroids. This is going to be another case here where steroids are going to be very beneficial to help kind of tamp down that immediate sort of inflammatory sort of response. So again, the pathophysiology is actually very similar. It's just a matter of what the targets are that the body's kind of aiming for, and again, having those associated signs and symptoms with that. So again, I'm not going to get very detailed into the specifics, but again, just know that the big issues for us is that we're going to be focused on, whether with CD, with Crohn's disease, it's going to be more diffuse. We're going to be looking more systemic therapies, more things are going to be working from the oral sort of standpoint. With ulcerative colitis, we're able to get away with more rectal sort of administered drugs, depending on where it's located at. Anyway, so looking at our options here, we're going to find that these options are going to be very similar between the two. The routes are going to be the big thing that differs between these. So we're going to find that we can use things like aminosalicylates. And again, we know that aspirin, salicylates themselves are anti-inflammatory, right? So that's going to be somewhat useful. We'll look at those. I'll talk about our corticosteroids. We're going to talk about immunosuppressants. One thing I will note here, when I say topical here, we're talking about ulcerative colitis or Crohn's disease. What do I mean? Do I mean on the skin? No. What I mean topical, because again, we are all just a bunch of tubes, right? you really get down to it. Topical still kind of means basically the GI tract. So again, if I was applying something rectally for these patients, that's considered topical therapy because again, it's not systemic that they're getting the effects from it. They're getting it from these local effects from it applying directly to that GI epithelia. Okay, so in this case, when I say topical, that's what I mean. And we're going to have certain immunosuppressants we can use. We're going to see some monoclonal antibodies pop up here. They're targeting specific inflammatory targets like tumor necrosis factor or interleukin-2. Some cases where probiotics are going to be useful. And in some cases, surgery is necessary, right? Sometimes we have to take out part of the GI tract in order to deal with that inflammation. Crohn's disease typically going to be pretty similar to ulcerative colitis, but antibiotics may be more beneficial here. Some bacterial overgrowth that occurs with those patients. In some cases, some antidiarrheals will be recommended as well. Okay. So our goals for these patients is try to resolve the inflammatory process, obviously, and try to reserve any kind of complication from occurring, whether they get a fistula that develops or abscesses. We're trying to prevent them from getting to that point there. And also if they have any kind of extra intestinal manifestations, right? Some more systemic effects are occurring from this inflammation, deal with those as well. And then try to maintain that remission, right? So again, deal with the flare-ups, get them back down to their baseline, and then hopefully maintain them in that point there. But again, a lot of these patients, they feel better, they feel like they're doing okay, and then what do? They go off their meds because they're expensive, or they're just kind of in some cases, a real pain in the butt to administer, and what happens? Never relapse, right? So again, it's one of the things where I've had a couple of students who were talking about some of their personal acquaintances and say, oh yeah, I got this one friend, and every time he gets back down to baseline and feeling good for 6 months or so, goes off his meds, immediately back in the hospital, right, for a flare up. So again, these are things that in a lot of cases may be lifelong medications that they're taking here, right? Okay. So getting into our drug options, we're going to have the aminosalicylates. So a couple of different options are going to be here. The first one we have is called sulfasalazine. It's actually a prodrug. And so what happens is the colonic bacteria actually break it down into sulfapyridine, and it's 5-aminosalicylic acid, right? Otherwise known as mesalamine. Mesalamine is going to be important because it'll be the basis for some other drugs we're going to look at in a few seconds. Basically, it's going to get broken down to its active components there. And then by working locally on that GI epithelium, you're going to be able to inhibit things like lipoxygenase. You're going to be able to inhibit cyclooxygenase. By doing that, you're just going to have these anti-inflammatory sort of properties here, right? Again, as far as adverse effects go, typically tend to be well tolerated, but again, you can see things like abdominal pain. You see things like diarrhea associated with these. That's not unusual, but be aware of things like blood dyscrasias, right? You can see bleeding being somewhat of a risk if you have too much absorption of that 5-aminosalicylic acid, right? So things to consider there. Now, mesalamine itself is probably more frequently used. There's a lot of different dosage forms that are available, so I'm going to show you just a few different ones. You don't need to know specifically which brand names are associated with which dosage form. I'm just really trying to illustrate to you the different options that are out there, right? And so as I mentioned, the 5-aminosalicylic acid, or mesalamine, is going to be helping to reduce that inflammation there. Again, the adverse effects are going to be pretty similar to sulfasalazine, but you lack that sulfa property here. And again, could be some cross-reactivity with patients with a sulfa allergy. So this may be an option where, if you have a patient who's on sulfasalazine but had an allergy, you can switch them over to mesalamine. Maybe not have any issues there. And so a lot of these options are going to be available to, are designed to work where they need to, right, within the GI tract. So for instance, when you see DR on a tablet, what do you think that means? Dominican Republic? Probably not. Doctor tablet? We always make the joke whenever we see DR Horton Homes, we always call him Dr. Horton. Because our first apartment, or our first condo me and my wife ever moved into, it was a Dr. Horton house, and so every time something would break, because invariably something would break, we would call the doctor. I get Dr. Horton out here. But anyway, that stands for delayed release, right? So delayed release tablet. That means it's going to be able to get through the stomach, through the small intestine, before it really has its true effects, right? So by delaying that release there, it's helping to protect the drug until it can get to where it needs to work, right? Again, so a lot of delayed release tablets. Notice as well, we have things like, Canasa for proctitis. This is going to be something that is actually going to be a suppository that's administered rectally, right? So again, by administering it right to the rectum, it's going to be able to work just right there for that proctitis. Very effective there, but it doesn't have to involve necessarily the rest of the GI tract. So by doing that, you're helping to limit some of the side effects. You can get to be much more effective right where it needs to be. And then sometimes we'll have these enemas. They're going to be useful. And again, if you imagine enemas, are they able to coat the entire colon? No. A lot of times you have to worry about things like gravity, or may be fighting us, right? So usually, how are patients administering these enemas? Should be standing up? No, usually they're laying down, right? What side do you think it should be laying down on? probably their left side, right? So that way it's going to be able to help kind of get that. And what you're going to find is those enemas have a hard time really getting across that flexure there. So because of that, this is you'll find the enema is really going to be beneficial for a more left-sided disease, but they can't really get more diffuse than that. And I'll show you a picture to kind of show you that delineation there. But these are things to consider, right? How do you actually administer these drugs where they can get and actually work where they need to work at, right? And so again, some of these you're going to try to retain them for as long as you can. It can be sometimes difficult to do depending on the volume that they're administering, because that increase in volume can stimulate defecation. So again, these are all things to kind of be considering. And again, looking at the site of action here, you can find things like a mesalamine suppository. Well, a suppository is not really going to go anywhere. It's going to stay there right in that rectal wall. It's just going to be really working on the rectum, right? Versus something like an enema, you're going to be able to find it can get to the distal colon, right? Versus things that are going to be more, things that are going to be applied orally, they're going to be able to coat the entire GI tract. So depending on which kind of dosage form you give, depending on when they actually kind of release their drug, you tend to find they can work on different areas. So which one do you think would be most beneficial for something like Crohn's disease? That pentasol, right? Because it's going to be able to coat the entire GI tract versus just working on something like just the rectum. Okay, so again, these are in consideration you're going to make based off of how they're presenting, what the scope findings are, depending on what you found is where the disease is really located. And so some other examples, things like osalazine, which is actually just a dimer of mesalamine, just means two of the molecules put together. They can be cleaved and can work. And then things like basalazide or colazal, another pro-drug, basically has the mesalamine plus is like kind of inert carrier molecule. I say inert, what does that mean? Non-reactive, right? It doesn't actually do anything. It's just a carrier molecule to try to get to where it needs to work, and then it can kind of be cleaved, and then the mesalamine can really kick in, right? So a lot of different options that are out there. They're really designed to work in very specific areas, right? So again, if I talk about a patient who presents with proctitis, what dosage form is most beneficial for them? Something like a suppository, right? If it's just left-sided disease, something like an enema is going to be beneficial for them. If it's more diffuse, if it's Crohn's disease, you're going to need something oral that's going to be able to coat the entire GI tract. Yes, sir.
I just understand. So for mesalamine, you just want to know. You don't want to know like no Rawaza, no Kanaza, no. You just want to know like what forms would you use for what type.
Yeah. So I mean, because again, the concept I think are the important thing to take away from this, right? So again, knowing the difference between Rawasa and Canasa, like you're going to learn that if you work with these patients, right? And you can look this stuff up too. But looking at like, okay, a patient comes in and they're only on say mesalamine suppository, that already kind of tells you something about their disease, right? They only need, that's the only thing they're on, that's the only thing they need. Okay, well, they'll probably just have a proctitis associated with this. It's not much more diffuse than that. Okay, that's good information to know, right? So before you even seen the patient or read the GI report, like you already know something about it, right? So little things like that, right? Or if the report comes back and just says, left-sided proctitis or left-sided inflammation, then you say, okay, well, an enema is going to be better suited for this patient, right? I don't need to use an oral option potentially that could have more side effects because of going through the entire GI tract. So little things like that, right? So get more conceptual based. Absolutely. This is the only thing that's important is the test and make sure that we all get across. I'm just kidding. Yes, of course, the test is very important, right? But I'm trying to think past the test into the clinical situations where this knowledge might be useful for you guys, right? Okay. And remember, you always get a free answer for the test. So I don't see what you guys are complaining about. Just kidding. All right, up next we have our corticosteroids. So we can use steroids here. And again, it makes sense we can use corticosteroids because they're very potent anti-inflammatory sort of agents here. Now, what do you think of the benefits of using a topical product, say for instance a rectally administered corticosteroid versus say something like IV methylprednisolone? Less systemic side effects, right? Now the GI tract, you can absorb a lot of stuff from there, so you're still going to see some effects, and so you may see more systemic effects from something like this than versus say like an actual dermal product, but it can be beneficial to limit some of those overall systemic side effects, right? So again, things like topical hydrocortisone, something like a suspension enema. There's suppositories, there's foams that are available, a lot of different dosage forms that are available depending on where disease is really kind of most pronounced there. Things like budesonide. Where do you see budesonide before? It was an inhaled corticosteroid used for asthma. This is actually an oral product that we can administer. This is actually nice because it has pretty extensive first pass effect, which means what? That means the bioavailability is pretty close to zero. So because of that, you see very limited systemic side effects, but it's able to work topically right at the GI epithelium to deal with that inflammation. So oftentimes I'll see patients on budesonide because of that fact, and that limits a lot of the systemic side effects you could see, which is very beneficial there. And then for patients who are coming in for an acute exacerbation, what do they need to be on? We'll probably need to step up your game a little bit and use something much more systemic. So that's where things like hydrocortisone, prednisolone, methylprednisolone, any of those are going to be fine to use. So either orally or if you need to go with an IV agent, methylpred, hydrocortisone are very good options there, right? And of course, we know the side effects from this. Now, ideally, do you want your patients on corticosteroids every single day? Ideally, no, right? We know a lot of the big side effects come about from that, the osteoporosis, the glucose, the edema, weight gain, all that kind of stuff, right? So again, ideally, we'd like to have them off of those. But you may find some patients that are going to need daily therapy. Obviously, the lowest dose possible is going to be beneficial. And if you can use something that's only working locally, like budesonide, is going to be very beneficial to kind of limit those systemic side effects, right? Okay, up next we have our immunosuppressants. Now some of these are going to look very familiar because we talked about them a little bit when we were talking about things like our antimetabolites that were used for cancer, right? So methotrexate is going to be playing a role here. We call these disease-modifying drugs. What do you think it means, disease-modifying? They have to slow down the progression of disease, essentially, right? So again, they may not be great for dealing with sort of acute inflammation. They may not be able to deal with the, sort of the acute symptoms of disease, but they are able to help kind of slow down progression and are very effective in the long run, right? And so these will come up again when we talk about things like, rheumatoid arthritis, when we talk about other autoimmune conditions. And so basically what these are doing is working through a few different mechanisms to try to tamp down the immune system from a more kind of global sort of sense here. So for instance, we have things like, our azathioprine and our 6-mercaptopurine. We know those are antimetabolites that are preventing DNA replication for things like the immune cells. If you inhibit that DNA replication, can the immune cells replicate? They can't, right? They have no DNA to do so, and they can't replicate. So there you go. So good immunosuppressant sort of effects there. Methotrexate, how did that work? Folic acid antagonist, right? So by inhibiting folic acid, again, the cells can't use that DNA or can't form that new DNA. They cannot replicate. So you can be aware a lot of these are going to develop some degree of things like myelosuppression. So you want to be careful with that. Now, these doses they're taking, how do you think it compares, say, for instance, to cancer? Much lower doses, right? So again, you're not going to see the same degree of myelosuppression, but typically lower doses. Maybe infrequently they're being administered. So for instance, like methotrexate, you can use 25 milligrams IM weekly, right? Just one time a week may be beneficial for those patients versus having to take something every single day or really big doses like you would see with cancer. Things like cyclosporin also work by not necessarily affecting the replication of the immune cells, but by dealing with the actual activation of immune cells. So for instance, cyclosporin will inhibit the release of interleukin-2. Interleukin-2 we know is a very important sort of messenger molecule between T cells to activate those. By inhibiting the release of interleukin-2, you inhibit the number of T cells to get activated, and thus the inflammation is going to go down, right? So in some cases it may be beneficial if you didn't want something that would be quite as myelosuppressive as methotrexate. Maybe cyclosporin is a good option. And again, a lot of these you may find also in use for transplant patients. Why do you think we'd use it in transplant patients? Right, so to prevent graft versus host disease, right? So again, if I gave you a brand new organ from someone else, ideally we're going to try to get them as closely matched to you as possible, but again, still foreign material we're putting into you, and so the body wants to react to that. And so these are a lot of the same drugs we're going to find that use as immunosuppressants to try to prevent that graft versus host disease, right? Just be aware with cyclosporin, nephrotoxicity is kind of a unique thing with that. So again, monitor for renal function because that's going to be something that can definitely come up with those patients. Okay, up next we have our monoclonal antibodies, and again I'm not going to go over every single monoclonal antibody that's out there because I was just getting a car worked on recently, and they had like HGTV or something on. There's like House Flippers, Indiana or something, whatever's on. But every single commercial break, guess what was on? Monoclonal antibody commercials, like either for Crohn's disease or lupus or whatever the case may be. Like there's every rheumatoid arthritis, I mean, like every single commercial break, there's another drug in this category, and it's like, man, there are a lot of these drugs out there. It's kind of like the blockbuster sort of drugs that are out there right now, and you're going to find a ton of Me Too drugs. But again, how do you tell a monoclonal antibody from other drugs? MAB, so you look on the end there, you know it's a monoclonal antibody right there. You know it's injectable only. You know there's risk for anaphylaxis, right? So again, those are things that are common things you know. So even if you have never heard of the drug, If you see Blectafluza, Canizumab, you at least know something about it, right? And you can at least appear confident when you're talking to patients. Oh yeah, I've heard of that drug before. And you're like, I've never heard of it. But you can go look it up, right, and figure out what it does. Again, not all of them are immunosuppressant, but these definitely are. And so, for instance, we have things like infliximab and adalimumab. These are going to come up again in when we're talking about rheumatoid arthritis. Again, I'm just showing you a few of the example ones. I'm not going to cover every single monoclonal antibody that's out there. You guys can look that stuff up. And by the time I get done with this lecture, there's probably going to be another one that just got approved, and my stuff is immediately out of date, right? Anyway, so infliximab. What's the X mean in there? Is infliximab going to give it to you? Thanks. I just thought of that one. No, it means it's chimeric, right? It means it's mouse and human protein. What does that mean for your patient? They're more likely to have a reaction, right? The more foreign the protein is that we're injecting, the more likely they are to have a reaction to it. So infliximab is one of those things we have to have patients who are coming in. They have to come into the infusion center, and they have to be usually pre-medicated. What kind of drugs are you pre-medicating these patients with? Diphenhydramine, right? Antihistamines. What else do you think? Body's having this reaction to these proteins, you're causing inflammation. What else could you see? Myalgias. You can see low-grade fever. What do you get for that? Tylenol. You give Tylenol for that, right? What else? Anything else? Sometimes the patient has a known reaction, but they still have to receive the drug. We'll give steroids beforehand, right? And that's where you always want to have those medications on hand as well. You always want to have PRN orders for Benadryl, steroids, and what else? Someone anaphylaxis, what are you going to give them? Epi, right? You got to have the Epi on board as well, right? You're not going to give that as a prophylaxis because you're going to feel terrible and the hypertension and your blood pressure is going to go up. But have it as on an on-call sort of basis there, right? To compare that to something like adalimumab, which is mostly human protein, this comes as an injectable pen. Patients can take it home. They can inject themselves. They don't have to come into an infusion center. So again, it's one of those things where sometimes patient compliance can be a factor here, depending on the type of drug it is. Having to come into the infusion center every couple of weeks could be really problematic. They have a job they have to think about, or if it's your kid and you have to bring them in, take off work for that sort of thing. So little things to consider there. All of them are going to be expensive, and all of them are going to have pretty similar sort of side effects, right? And we were talking about the sort of anaphylactic, anaphylactoid sort of ones there. Also be aware that you do need to check for TB beforehand. Because why? They have a latent infection. You don't want that to activate because, again, these are immunosuppressive. So you got to make sure you check for that beforehand. And also be aware that this is sometimes worsen edema for patients with CHF. Worsen CHF, so be aware of that and be very cautious. Yes, sir?
You said adalimumab is not chimeric?
That is not chimeric. It's more human-based protein. I can tell that based off the mu mab on there instead of the X. So again, little things and again, that's more trivia more than anything else. But again, it's one of those things that really kind of influences, well, why don't I ever see patients coming into the infusion center to get Humira? Because they don't need to, because there's very low risk of having anaphylaxis as compared to a chimeric product like infliximab. So little things like that can kind of, little context clues that can kind of key you into, oh yeah, why do we do this versus that? Sometimes these little clues can give it away, right? Anyway, also looking at probiotics. I'm not going to talk about this too frequently or too much here. There's a lot of different probiotics products that are out there, and unfortunately, because they're so homogeneous or they're so heterogeneous between them, we're going to find that we don't have a lot of good studies saying like, well, is this one better than this one? Who knows, right? We don't have the studies to show us, and also it's not as well regulated as something like a typical medicinal product. So basically, what are probiotics though? They're like the amateur biotics. They're like really got to step up into the limelight. No, these are going to be things that are trying to be, they're helpful bacteria. They're typically things that are non-pathogenic, right? I'm going to be able to administer these, and hopefully they're going to try to outgrow any kind of deleterious bacteria, things that may be pathogenic there. Some people believe that it could be somewhat anti-inflammatory overall. If you get rid of some of those pathogenic bacteria your body could be reacting to, but the studies are kind of out on that. We don't really know for sure. Some people recommend it, some people won't. You do want to be careful with really immunosuppressed individuals that sometimes you can actually have infections that can occur from probiotics. Again, low risk, but it's something that has been noted before. Okay, and then as far as antibiotics go, we can see that in some cases it can be beneficial to try to decrease the concentration of some of the pathogenic gut or bacteria that are in the gut there to deal with some of the inflammation. This is more seen with Crohn's disease than it is with ulcerative colitis, typically because you get more of these fistulas and things that can develop where the bacteria kind of get sequestered off. They can sit there and just kind of fester and cause a lot of inflammation. So you typically see more antibiotics used here. And again, what type of antibiotics would you think about using? Typically gram-negative coverage, maybe a little bit of anaerobic coverage, so things like ciprofloxacin or Flagyl are going to be good options that are there, right? So by using those, it can help to deal with that, that small intestinal bowel overgrowth, essentially. So anyway, so looking at the specific treatments between ulcerative colitis and Crohn's, we're going to get into specifically how the management is going to differ between these two. We're going to find that obviously with ulcerative colitis, they're trying to decrease the number of relapses that they have, try to get them at a good stable baseline, and hopefully prevent any progression of disease, kind of keep them as stable as you can. And again, treatment very, very dependent on the location and the severity where it's at. So looking at this, you see here that if it's just proctitis, what's going to be a good dosage form there? Suppository can be sufficient there, right? It's fairly easy from that standpoint to reach those areas that are affected. If it's more of a left-sided colitis, enemas are good for that, right? You're going to be able to get enough fluid that's going to be able to coat the left side of the colon there. Again, gravity can be kind of not your friend here, and so you're going to find that at this point, this is where oral therapy is going to be much more recommended, right? So again, it's more diffuse ulcerative colitis. You're going to have to use oral products in order to make sure you coat the entire colon. Make sense? So looking at this, you can kind of see based off of the disease severity, you're going to go on a step-by-step approach here, right? So again, ideally, what kind of dosage forms or what kind of products am I going to use kind of first line? I'm going to go with like the monoclonal antibodies and the antimetabolites and all. No, am I going to corticosteroids? Not typically, right? So again, assuming I'm having someone who's just been diagnosed or not an acute flare-up, start off with topical products that have limited side effects, right? So again, start from the oral sulfasalazine, easy. Considering, where they're at as far as how diffuse it is, you may need to use oral, you may need to use rectal products, but again, you guys know the difference there. You know what to recommend based off if I ask a test question and say, hey, it's just a left-sided colitis, you're going to tell me, okay, enema is a good option for that, right? But again, if it's going to be more diffuse, this is where you're going to see things like, your topical corticosteroids can be used here, and budesonide is a good option here. Budesonide is good because, as I mentioned, low bioavailability, limited systemic side effects, so it can be a nice option from that standpoint. And the goal is to try to downgrade your therapy as best you can based off of how they're responding there, right? So if you have them on, say for instance, on budesonide, they're responding well. Say you start them on that and sulfasalazine, scale them back down just to the sulfasalazine, see how they respond to that. If it starts to flare up again, you may need to keep them on the corticosteroids for longer, right? Now, for more severe disease, this is where we're going to start to consider things like prednisone, right? So against more moderate to severe, prednisone daily can be used. And again, prednisone, anyone like a typical treatment dose they have like an asthma exacerbation for prednisone is? It's like 60 milligrams a day, right? So again, this is a pretty hefty dose you're administering to these patients here. You're going to see those side effects, right? You're going to see the hyperglycemia. You're going to see the risk for osteoporosis. You're going to see all these different problems associated with that. So, because they're going to be very careful. And then the ideal thing is you can then scale off of them, right? You can hopefully go back where you don't need any corticosteroids being administered systemically. That's a benefit. If they're not responding to that, that's where you can consider some of the things like the antimetabolites, azathioprine, mercaptopurine, methotrexate, and this might be a good option. Methotrexate you see probably a little bit more in Crohn's disease, but certainly azathioprine and mercaptopurine is a big one here. This is also where you can potentially introduce the monoclonal antibodies. And in fact, what I see with some of our GI docs, and again, this is just more specifically for peds, what I've seen, is that for more moderate to severe disease, we're going to just start them off on something like Humira. And we actually have a program set up with the drug company. That way they actually get the first dose for free in the hospital. And then when they go home, the drug company works with them and their insurance partners to try to make sure that the patient can continue their dosing there, right? So it's a benefit to us as a hospital because we get the drug for free from the drug company. The patient gets a free first dose. And then just like any good drug dealer, the first dose is free. Then you got to pay. So, but fortunately, the drug companies are working with them because it's in their benefit for the patient to continue receiving that drug, right? And again, it's beneficial to the insurance companies to keep your patient out of the hospital with the flare-up of their UC or their Crohn's. So it kind of works for everyone to try to keep them as healthy as you can because it's going to be cheaper in the long run, even though those meds are very expensive, right? So anyway, and again, for more severe disease, this is where you want to consider using things like IV corticosteroids, hydrocortisone, methylprednisolone, any of those things to try to really tamp down that inflammation and then get them stabilized on something else, right? Switching back to an oral product, then scale back down as you can. So again, it's a stepwise approach, okay? So if I had a patient who's coming in with a flare-up and they're on, say, sulfasalazine and, say, oral budesonide, coming with a flare-up to the ER, what would you start them on next? There's severe pain, bloody diarrhea, IV steroids, right? IV steroids are a good option at that point, right? And then eventually scale it back down, okay? So you can kind of think about where they're at in the algorithm, where you're going to step up to next. Now, if they weren't coming in for a flare-up, say they're coming into your clinic, your GI clinic, and say, hey, I'm still having symptoms, and the sulfasalazine is really working for me, then that's where you can consider stepping up, maybe using something like adalimumab or infliximab or something like that, right? So again, it's always a stepwise approach. And notice here, when it's even more severe than that, is where cyclosporin can sometimes play a role. Cyclosporin, is very, very potent, but can be somewhat toxic, especially from the nephrotoxicity you can see with that. So again, that's where you're going to be seeing those used occasionally. But again, all stepwise, right? Again, the ideal thing is to scale them back whenever you can. Now with Crohn's, same goals are going to be here. And again, it's going to be dependent on where the disease is mostly located and the severity thereof. So with this, what you're going to find more is, again, are you going to use any enemas, any rectal products with CD? No, you're only going to be using oral products there, right? So again, things like sulfasalazine, mesalamine orally are going to be used there. Now again, here you may also see this is where antibiotics are going to come into play. You notice antibiotics do not play a big role for ulcerative colitis because you typically see these little fistulas and abscesses forming more so in the small bowel there. So this is where metronidazole and/or ciprofloxacin can be used. Metronidazole gets your what kind of bugs? Anaerobes, and Cipro gets your gram negatives, right? So again, this is a good combination to use there if they need it, okay? Again, if they are having particular symptoms that are more, located in the colon, you can still use some of those products, but it's not as common. Typically, they're going to use more oral products there. And again, it's all stepwise. Again, if they're using the steroids, try to consider moving up to a monoclonal antibody, infliximab, adalimumab, any of those are fine. If it's a monoclonal antibody I didn't talk about, it's mainly because I was trying to do it in the interest of time, so I will not put it as an answer choice on a test. But certainly Humira and infliximab are going to be on there. Okay, just FYI, as options potentially. Again, things are not working. Step it up. Use IV corticosteroids. Right. Similar approach. The main thing here is you're going to see more antibiotics being used more in Crohn's disease, and then the dosage forms have changed a little bit. Right. Okay, and obviously as far as maintenance goes, try to limit how many drugs you're having to use, get them down to the smallest dose as possible. If you can get them off the oral corticosteroids, that's always going to be the most beneficial thing you can do for them in the long run. Now again, when I say oral corticosteroids, I'm referring to prednisone. I'm not talking about budesonide. Budesonide, when I say that, I'm going to be more referring to it as a topical corticosteroid, even though it's given orally. That makes sense? So again, when I say systemic corticosteroids, I'm referring to things you can take orally that get systemically administered, but budesonide is the exception to that because it has such a high first pass metabolism. Got it? Okay, so keep that delineation in your mind there. And again, corticosteroids should have no role in maintenance therapy. You need to get them off of that as best you can because the side effects we know, especially in the long term, are going to be too severe. They need to get off of as best they can. Okay. Now going into irritable bowel syndrome, what is this? What can be some things that can trigger off irritable bowel syndrome? Well, stress. Maybe some of you are affected. Who knows? I don't want to know about it. Just saying, some of you maybe. But yeah, so basically, and again, you can have IBS that's either associated with constipation, or IBS is going to be more associated with diarrhea, and the treatment is going to differ pretty greatly between those two, as we'll see. And again, typically women tend to be a little bit more effective than men, and again, that can be somewhat important for a few of the medications, some of the more restricted ones we're going to talk about in a second here. A lot of times we don't know what's going on here necessarily. It's certainly not inflammatory in nature, at least not so much as it is in something like Crohn's disease or ulcerative colitis. Some people believe some dysregulation of things like serotonin transmission. We see there's a few serotonin acting drugs here in just a little bit. Some people feel that it could be just psychological. Some people feel it could be due to bacterial overgrowth. There's a lot of different options that are out there, but we don't really know the full story yet. As I mentioned, we have IBS with constipation, which is IBS-C, gets abbreviated, IBS with diarrhea, which is D, and then you have sort of mixed type, and then some unsubtyped IBS, kind of some pain bloating associated with that. But again, mainly we're going to focus on whether it's IBS with constipation or diarrhea. This is mainly what our drugs are going to be geared towards. Obviously, reducing symptoms, and the main thing is like trying to make sure that patients are able to, continue with their activities of daily living. They can go to work, they can do their thing, improve that quality of life. So, big things to note here with the non-farm therapy is mainly like just monitor things and make sure you're keeping a journal. Like what were the things that kind of triggered a certain event? What were the things that worsened it? What are the things that make it better? And that way they can try to look for those things in regards to the non-farm therapy. Obviously, increasing fiber can be beneficial both for diarrhea and for constipation. Very useful for helping kind of regulate the stools there. And avoid things like excessive caffeine, fatty foods, things like that. All right, so getting into the actual drugs we're going to see being used here. Now, IBS with constipation, we already talked about most of the drugs already, but we're going to find a few new ones here. IBS with diarrhea, again, we're going to find just a few new ones. But notice here as well, there are things like TCAs. Why do you think TCAs might be useful? Or SSRIs? Not for anticholinergic effects. So no, anticholinergic effects could be useful for what type? For diarrhea. Would not be good for constipation. Because what's the side effect of anticholinergic? Constipation, right? So again, not good from that standpoint. But what else does a TCA do? Cause some sedation, but I don't need my patients to be sleepy. They're having problems with their tum-tum, right? What are you gonna do? So think about it. We talked about serotonin possibly playing a role here, right? There could be some dysregulation of serotonin. So by using something like an SSRI or TCA that can maybe help to dysregulate or try to get that regulated back and kind of level it out, maybe it'll be somewhat useful. So again, that's why we're going to find that that can be useful for some patients, not necessarily with all of them. But again, as well, like what was one of the big triggers for irritable bowel syndrome? Stress, anxiety. If I give them something that helps with their anxiety and stress, a big heaping dose of Zoloft, and they're so chilled out that they don't even care about what is going on around them, that can be very useful, right? They can help to decrease some of the symptomatology there, right? And we're going to find if you have this small intestine bacterial overgrowth is where something called rifaximin can be used, and I'll talk about that just briefly here in a little bit. Rifaximin is going to be kind of chemically related to rifampin, if you guys remember that drug, right? Rifampin, what do we use that before? TB and endocarditis, yes. I heard someone whisper it. Very good. As you mentioned with your bulk forming laxatives, again, this is your psyllium husk, this is your Metamucil, this is your methylcellulose, all that good stuff. Any of these are fine. You're typically going to find that these are good for either constipation or diarrhea, and it seems like it could be kind of counterintuitive, but again, it helps to kind of just regulate everything, helps to kind of get things back down to normal, right? So again, if they're constipated, it's going to help to bulk up that stool, it's going to get it emulsified, make it easier to pass. As diarrhea, it's going to be able to kind of hold things all together a little bit better, and hopefully help to give a little bit more form to the stool, and hopefully prevent that diarrhea. So fiber, non-soluble fibers, very good for either one of these. The other thing to note as well, because I said it comes as a powder, obviously has to be put back into solution. Make sure they're drinking with plenty of water. And again, the stuff is going to swell up, and it's going to cause some abdominal pain, some cramping potentially. But they need to drink it with plenty of water. Okay, that's the other big thing to know with that. The osmotic laxatives, we talked about these. These should only be used kind of on an as-needed sort of basis for the most part. Things like hydroxide, that milk of magnesia. Again, it's more for acute cases of constipation here. I mentioned Miralax. Now that's available over the counter. People can take it every single day, so you can kind of lump in with that category of like the non-soluble fibers. But occasionally you can use bigger doses if you're having an acute case of constipation to kind of move things along, right? Now, some of the new drugs we have here, so this is actually going to be a chloride channel activator. So basically, this is a lubiprostone, or Amatiz is going to be this derivative of PGE1, which PGE1 is prostaglandin, right? So again, it's basically a derivative of prostaglandin. One of the things you're going to find is it actually works to increase this intestinal secretion secondary to chloride channel activation. So basically, you're releasing more chloride into the GI tract. Other electrolytes are going to come along with that, and so basically, water comes along with those electrolytes. Okay. So again, it's going to be able to help kind of increase the bulk there. It's going to increase that stretch and stimulate defecation there. So it can be a very useful drug. Again, for the most part, very well tolerated by patients. No big side effects associated with it. Mainly because it has no systemic absorption, and so it really limits those systemic effects. Now, TCAs, as I mentioned, pretty dirty as far as how they're working because they work on so many different receptors. Again, they tend to be causing a lot of sedation, and they can cause constipation. So if they have IBS-C, it could be potentially worsening it, as the case may be. But can be very, very useful for some patients there. And again, recommend they take it at bedtime, due to sedative sort of effects there, not when they're getting up and have to go sit in class for 8 hours or whatever the case may be, right? And again, when do SSRIs and TCAs kick in? A couple weeks, right? When do they get adverse effects? Immediately, right? Hours, versus the therapeutic effects take weeks there, right? So just be aware of that. Again, if they had IBS-C, I'd probably more lean towards using something like SSRIs, because again, they're going to be least constipating as compared to your TCAs, right? Okay, so here are some of the newer drugs here. So these are going to be partial agonists of the 5-HT4 receptor. We haven't really seen anything that works on the 5-HT4 receptor yet. These are the new ones. Basically, when you stimulate this, it causes peristaltic reflux to kind of kick in. And so the drug we have here is called Degaserod. Just note this one is going to be available only through an IND. I've never heard of an investigational new drug application before. It's kind of interesting. So you can't just go to your pharmacy and just pick it up. You can't just write for it. It's basically one of these things where you have to apply through a specific program in order to get this, mainly because they're worried about certain cases of causing ischemic colitis, very serious cases of diarrhea, because by activating this reflex, you're going to be stimulating peristalsis, right, and causing diarrhea. But actually, it's only indicated for women. Actually found with men, it actually didn't work any better than the placebo did. So this is a medication that is only for the ladies. With IBS with constipation, right? Because it's going to be able to stimulate that peristaltic reflex. But it's very hard to get a hold of. Really going to be used for more refractory patients. Other things are not working for, because you have to go through all this extra kind of paperwork just to get enrolled in the program to even take the drug. So just be aware of that. As far as antidiarrheals go, we've talked about these. Loperamide can be very useful here, working on the opioid receptors. Even cholestyramine can be used occasionally. And cholestyramine we saw where previously? It's a bile acid sequestration. Sometimes it can actually act, try to decrease or try to bind up some of the fats in the stool, and that can sometimes help to decrease some of that diarrhea you see with that. So it can be used occasionally. Usually going to be used for patients who are maybe not responding well to loperamide, or if you imagine people who are post-cholecystectomy. Why do you think that could be the case? Because they're not releasing their own bile salts, right? So again, you're kind of using this as kind of a replacement to try to decrease some of that fatty content of the stools there. So that's why we'd end up using that in those patients particularly. And then here we have a 5-HT3 receptor antagonist. Now we saw this previously with Zofran, being a serotonin 3 receptor antagonist, but this one's called Elocitron. This is going to be better for women with severe IBS with diarrhea. This is another case where you can find some big issues of ischemic colitis seen with this. So again, for refractory patients only, if they failed everything else, this is where you can see this being used. And again, really only found benefit in women. And obviously, a lot of contraindications associated with, especially if they have any kind of bloody diarrhea or any kind of worsening abdominal pain, anything like that, discontinues immediately. So not used frequently, but could be useful if they failed everything else. Hope you don't mind if I go just a minute or two over. You guys will hang with me. Other things to note as well is if you have patients coming in with abdominal cramping, we can use that antispasmodic agents. Most of the time these tend to be anticholinergic agents, and I'll show you a few of these in a second. They can help to decrease some of the muscle cramping that happens in the GI tract. But again, you're going to see the same sort of anticholinergic side effects like we saw with things like scopolamine, like we saw with our first generation antihistamines. Same thing happens here. And I'll show you some of the agents here. And just note that tachyphylaxis can happen, so you see some tolerance to the effects over time, so it may not retain efficacy for the long term. But here's some agents we can see being used. Things like hyoscyamine, things like dicyclamine, glycopyrrolate, clendinium, and sometimes you'll see actually a combination of hyoscyamine, scopolamine, atropine, and phenobarb. It's a very old sort of drug called Donatol we don't use too frequently. I will tell you that if I have a lot of patients coming into the ER with abdominal cramping, hyoscyamine is probably the most common one. We'll use a very good anti-spasmodic sort of agent. Again, use it sparingly because you do see that tachyphylaxis associated with it. Glycopyrrolate is also really good. Robenol is used for a lot of excess respiratory secretions. We actually use this pretty frequently for a lot of like our vent-dependent patients and things like that to try to help dry up their secretions and help them oxygenate a little bit better. Then, as I mentioned, antibiotics can be somewhat useful. Rifaximin tends to get used here most frequently. Beneficial because it works locally, not actually being absorbed, is able to deal with that small intestinal bowel overgrowth, right? Very good from that standpoint. Okay, so anyway, so looking at this, obviously the therapy is going to be dependent on if they have IBS with C or IBS with D. But looking at this, again, fiber is going to be recommended for either, for the most part, because again, it can be beneficial for either here. And then looking at it further, for diarrhea, you're going to use your antidiarrheals. For constipation, you're using things that are stimulate the constipation or stimulate defecation there. And again, looking at things like your TCAs, your SSRIs can be useful to help kind of regulate that serotonin effect. Okay. Thanks for sticking with me for that. I'm gonna check the board real quick just to make sure there's no questions.